Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. Today we're going to talk about something that's important to understand if you have diabetes, and that is heart failure. This is a scary sounding term, and because it occurs all too commonly in people with diabetes, and because early detection of heart failure can lead to early treatment, and early treatment can lead to better outcomes, it is really important for those of us who have diabetes to know what heart failure is and to understand it. This episode is being sponsored by Roche. I'm Dr. Neil Skolnik, Professor of Family and Community Medicine in the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me as always is my co-host.
Thanks, Neil. I'm Dr. Sara Wettergreen, an assistant professor at the University of Colorado Skaggs School of Pharmacy and an ambulatory care clinical pharmacist.
Today we have one of the country's experts in heart failure joining us, Dr. Jim Januzzi. Dr. Januzzi is a professor of medicine at Harvard Medical School. He is a cardiologist at the Massachusetts General Hospital and chief scientific officer at the Baim Institute for Clinical Research. He has published more than 900 manuscripts, has edited 5 textbooks, and is a deputy editor at the Journal of the American College of Cardiology. He lectures nationally on testing and treatment of heart failure. Welcome, Jim.
Thank you so much, Drs. Wettergreen and Skolnik. It's really great to be here.
Jim, the term heart failure, even just those words, I think can be really scary for people to hear. Can you explain for our listeners what heart failure is?
Sure, Neil, and you're absolutely right. The term is a scary one, but it's important to acknowledge that heart failure is a scary diagnosis. And on the one hand, we are definitely making efforts to rebrand the diagnosis by referring to our heart failure clinic as our heart function clinic. But on the other hand, we also do not want to reduce the implications of the diagnosis, because our patients really need to understand that much like other forms of chronic disease associated with a high risk for morbidity and mortality, such as cancer, for example, we have effective treatments for heart failure. So we want to make sure that our patients understand the gravity of the diagnosis so that they match the gravity of the diagnosis with the aggression of treatment that we can offer for them to improve their prognosis.
That's so well said. And it's so important for people to understand that treatment often involves a good deal of medicines, a lot of doctor's visits. The one thing I do want people to understand about that term heart failure is it doesn't mean that the heart has stopped working, i.e. what we sometimes think of as failed, but rather the term is meant that it's failing to keep up with the needs of the body. Is that a good way to think about it?
Precisely. So the strict definition is exactly what you just said, which is it's an inability of the heart to maintain the needs of the body and in terms of its cardiac output. And that can be due to any number of reasons. So although the immediate fear is that the heart has weakened to the point of irretrievably no longer squeezing, which is a form of heart failure, there are many shades of gray between this and often what we see, which is completely normal heart function, and yet a person develops heart failure for other reasons, such as an impaired relaxation of the heart muscle rather than a weakened squeeze. So it's necessary for clinicians to explain the term, explain why heart failure may be present, and importantly, the treatments that we give for heart failure vary depending on the underlying cause.
And so that our listeners understand, what are some common symptoms that they might have with heart failure?
Yeah, thanks very much for that. So, common symptoms of heart failure overlap really dramatically with many other diagnoses. And that's why we are in the heart failure community always concerned about making sure that your listeners and others know what to look for. We try to simplify things by focusing on the cardinal symptoms of heart failure, which include fatigue, shortness of breath, swelling of the legs related to congestion, palpitations and rapid heart action. These are all nonspecific but indicate the underlying pathology of heart failure, which includes the retention of fluid, the irregularity in heart rhythm. All of these things are cardinal findings that we look for when we're examining our patients.
Thanks for describing that. And you're exactly right. I feel like these symptoms are quite common, but in particular, isolated. When we see all of these together, it seems more likely that it could be a concern for heart failure. So if someone has multiple of these symptoms and they're trying to distinguish, what is this from? Could it be heart failure? And they go to their cardiologist, what can they expect in terms of how a diagnosis of heart failure is made?
Yeah, great question. And indeed, these cardinal symptoms, to some extent, the clinician has to look for them too, right? Because my patients will tell me, gosh, I thought I was just getting older, that the fatigue was just related to me being at a higher age.
Yep.
We talk about in heart failure the so-called phases of heart failure: fatigue, activity intolerance, congestion. These are the sort of the cardinal symptoms, and then shortness of breath also. So clinicians need to look for these things and think of the diagnostic steps that they might take. The good news is that we have simple diagnostic tests that are highly sensitive to identify the presence of heart failure as a diagnosis. So if a clinician suspects the diagnosis and orders these tests, it's likely they will successfully identify it. And the simplest, probably, besides physical examination and taking a good history, include an EKG to look for irregular heart rhythms, and then blood tests, including something called a natriuretic peptide test, which is a now globally available blood test that, when elevated, identifies the presence of heart failure with very high sensitivity. If any of those tests are abnormal, then the clinician would turn to the next level of testing, which is typically an ultrasound of the heart muscle, something called an echocardiogram. And together with the clinical history, physical exam, blood testing, EKG, and echo, most of the time we can nail the diagnosis of heart failure with reasonable certainty.
It's interesting. We've talked on this podcast many times about the importance of patients being empowered to ask their clinician about things. And Sarah, you mentioned, and Jim, you mentioned how common those symptoms are. And Jim, you said a lot of people just get fatigue with aging, a little shortness of breath with aging. And that is so true. But in the context of having diabetes and in the context of having hypertension along with it, I'm going to suggest to our listeners, if you are having that shortness of breath and fatigue that's more than you think you should have, don't be afraid to ask the clinician, because we don't always know quite what you're experiencing. And one of the goals is to empower our patients. Jim, it looked like you had a thought.
Yeah, absolutely. Agree entirely that empowering our patients is critically important, because we, not as physicians, but we as people, try to make sense of our reality. And again, I cannot tell you how often I've had my patients say, I thought this was related to getting older, or the shortness of breath at night I thought was from postnasal drip, right? Trying to understand and to some extent deny the potential gravity of the situation. And let me give you an example of why this is so critically important. We recently did a clinical trial of a diagnosis called diabetic cardiomyopathy. This is a diagnosis of heart failure where chronic diabetes may result in weakening of the heart muscle, just purely from elevated blood glucose. It's a well-described diagnosis. What we found in this study was that among 800 people with diabetic cardiomyopathy who had no prior diagnosis of heart failure, the average person in this study had no complaints of that would lead us to a diagnosis of heart failure, and yet when we did an exercise test on them, they were markedly impaired. So it's necessary for us to be introspective, clinicians and patients alike, about making sure that we are not missing these symptoms, because again, a simple blood test like a natriuretic peptide would identify that problem with great sensitivity. For that reason, the American Diabetes Association is now recommending that individuals with chronic diabetes get screened with natriuretic peptide testing by their clinicians on an at least yearly basis in order to identify the presence of unrecognized heart failure.
It's fascinating. One of the things that you said reminds me of what I see a lot in the office, which is people who are functional people who function well often restrict their activity so as not to provoke symptoms.
Yeah.
And so the fact that someone doesn't have symptoms sometimes occurs because without even realizing it, they begin to do less. And it wouldn't surprise me in the study that you just mentioned if that is part of the explanation for what you described. And I am certain is the explanation for what I see in the office sometimes. And it really underscores the importance of screening. Sarah?
Exactly right. I think too, just hearing that statistic, I wonder if any of our listeners are going to be nervous about that. The fact that, even without symptoms, there was this risk. So I think it's really helpful to know that this is a new screening recommendation and that you don't have to sit and worry if this is something that's possibly going on with you and you don't have symptoms. It's something that you can have those conversations about with your care team and have the screening performed annually to have that either reassurance to know lack of symptoms doesn't always mean lack of problem from this example. But also then to have that early indicator of if you do experience these symptoms, is this fatigue in this individual person's case that sign of aging or differences in energy, sleep, function, or is it something like a cardiac condition such as heart failure? So I think that information is super helpful for our listeners. And jumping ahead a bit in our conversation, but thinking about that, it can be hard for someone to be aware of this test and maybe not have symptoms, but want to receive this screening and to bring that up with their care team. So what are your recommendations on how an individual might bring this up with their care team to seek out this screening, since it is a relatively new test or frequency of the test, and our provider may or may not know about it?
Yeah, great points. Multiple things to address here. One of which is that, yes, it's a new recommendation by the American Diabetes Association, but it is now in the standards of care, which is important to emphasize. And furthermore, the test itself is not new. It has been around for around 20 years, but we typically would test it in people who are more highly symptomatic. But it's become recognized in recent years that the test is actually abnormal even in people who have more minimal symptoms, number one, or really importantly, it may actually rise as a leading indicator even before symptoms develop, what we refer to as stage B heart failure. These are people who don't yet have symptomatic failure. And the reason why this is so important, whether a person does or does not have symptoms, if they've got an elevated natriuretic peptide, the likelihood for major complications, including hospitalization, goes up. Why is that important? Because we have treatments that have been unmistakably shown to lower the risk for progression to symptomatic failure or hospitalization or death from heart failure, including, by the way, therapies for diabetes themselves, the sodium glucose cotransporter 2 inhibitors, the GLP-1 receptor agonists. These are drugs that not only are effective glucose lowering therapies, but they are also therapies that reduce cardiovascular risk rather substantially. It's like bringing coal to Newcastle to be bringing this up on an ADA podcast, but the sad reality is that nationally, even people with an indication for an SGLT2 inhibitor or GLP-1 receptor agonist, fewer than 20% are receiving them. So we really do need to get all hands on deck, not only to identify the people who are at risk, but get them treated. Now, one last point, which is really what you asked me, which is when a patient sees their clinician and they are motivated and educated, it's important, obviously, for them to educate their clinician if their clinician is not aware of the ADA recommendations, because the test is available and the therapies that we can use to reduce the risk are available. So there's no reason not to do the testing.
I think that's such an important point. And the reality is, and I can talk here as a primary care doctor, there is a lot of change going on in every area of medicine where we take care of patients. And this is a recommendation that literally just came out this January. It's hard to keep up with everything, and I wouldn't think less of your primary care doctor if they didn't know this, but it's helpful if you know it now. You can mention it to them, they can look it up, they can do the test, and most of us in primary care, I'll say, are pretty humble. We know we can't know everything, and we appreciate that working together with our patients in order to achieve the best outcome for our patients. We only have a few minutes left in the podcast. Jim, any final thoughts you have?
The advances in care for diabetes that have had such a broad-based effect, beneficial effect on what we now refer to as the cardio-kidney metabolic overlap, have revolutionized how we as cardiologists approach our patients. And we have the ADA, the diabetes community to thank for that, because it has really brought the effects of chronic metabolic disease into a much sharper focus for us cardiologists. And to the extent that nearly half of my patients have diabetes and a substantial percentage have prediabetes, I think it's really necessary to once again say that we all have to get all hands on deck to recognize the risk and get our patients treated, since we do have effective treatments available.
Thank you so much. Sara, any final thoughts you have?
My final thoughts are around potentially someone who might have some fear about a different diagnosis, and knowing that the risk of heart failure is something that we think about in people who are living with diabetes. And so with that in mind, I think that there can be this tendency where if someone has shortness of breath, they might be worried about, what does this mean for my health? Is this a risk of a heart attack? Is this risk of heart failure? What does this mean for me in the long term? And how does that affect my long-term view of my life? And in my own practice, I see sometimes patients will avoid additional testing and screenings to avoid finding out that information. And so my final thought is really just around empowering the individuals to try to avoid the fear of the test. Whether or not you have the test or not will help. It'll help you to have the information to be able to do something about the outcome, because your body is what is going to be either way. And so the more information you have, the more you can act on that and find different solutions to support you as you continue living a wonderful life.
These are critically important suggestions. To summarize for our listeners, there has been a new recommendation by the American Diabetes Association to screen on an annual basis for heart failure, an important complication of diabetes. And that screening is done with a simple blood test, a BNP, or sometimes called a NT-pro BNP. B as in brain, natriuretic peptide. And that is in order to catch the diagnosis of heart failure before it's symptomatic or when it's only mildly symptomatic. Dr. Jim Januzzi, thank you so much for joining us.
Thank you so much for having me, both of you.
And Sara, as always, thank you. And most of all, of course, thanks for our listeners. We also want to thank Roche, who is the sponsor of this episode. And now, for our listeners, in an upcoming episode, we will be discussing apps that are useful in the management of diabetes. If you have a favorite app, give us a call. Leave us a message at 703-755-7288. That's 703-755-7288. We'd love your suggestions. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thanks for listening.